All right. Strength Students Podcast. Browsers. Scene number 69.
Doing 69.
3 guys, one medical, surgical, implanted ankle. Take 1. All right, guys. Everybody, welcome to the Strength Students Podcast. We're here with Cory Schwarzkopf.
Yep, Schwarzkopf.
Schwarzkopf.
Mm-hmm.
Nice. What
like
is
the
that?
general.
It's German. I'm Italian. It's kind of a weird story. Schwarzkopf.
Okay.
You're related to General Schwarzkopf.
Yes, that's a fact.
That's
that actually
right.
comes up a lot, but yeah.
And we're here in White Plains, Connecticut. At
New York, you mean?
What did I say? Oh, fuck. Dude, like, with our states.
All right, it's over.
States are just like divisions. Just so the government can like hold us down.
There you go.
So we're in White Plains, New York. We're at this place where there's a bunch of fake feet and fake knees all over us.
This is it. This is
No, just kidding.
second home.
So we're here learning mainly about you, Cory, what you do, but a lot about today the focus, which is going to be low carb diets, why that's beneficial to many spectrums of people who are looking to get healthier, general fitness people, and maybe some athletes as well. So
Absolutely.
excited to get started with that, man. So
Yeah.
so what are you up to now? Like, what do you do? What do you do here in White Plains?
Yeah, totally. So, first, I really appreciate you guys coming down. This is great.
Yeah.
I'm really excited about this. So currently where we are in my office, our office, I do medical device sales. And so we are working with doctors, not just to have them try, innovative technologies for arthroscopic orthopedic surgeries, but also there's a consulting aspect of letting these doctors try different techniques for certain procedures, whether it's rotator cuff, ACLs, Achilles tears, things into the feet and ankle, things into the hand and wrist. But it's a very exciting field, and it's cool to be able to take some of the basic knowledge of anatomy and see it live. And
Well, yeah, we were talking before. You're literally in the room when they're performing surgery on someone, putting one of these prosthetics into someone's body.
Absolutely. There's definitely a lot of responsibility with it. Take it very seriously. There's a lot of studying. It does remind me of being in grad school and, what it takes to actually know this stuff. And it's one thing to, study for a test and, do well in it. It's another thing to really know the information, how to apply it. And then just, kind of your, part of the sales aspect as well is just, being helpful to the team. So there's been times where you help with the competitor's product. Maybe they have the wrong size in the room and, you want to just help out, or you help the nurses change the IV bags or anything like that. So it's very exciting. And, it's a lot of work, but I really do enjoy it.
Well, when we were talking before, too, it's the part that, like, intrigued me the most is, like, so you're a title, you're a surgical salesman almost, essentially, right? But like we kind of mentioned before, you're literally in the room with their surgeon while he's performing surgery. So these prosthetics that you sell to them, you're also in there giving them advice and kind of guiding them in the right direction of how they should be installing it. These are doctors, right?
Correct.
And kind of
They
like
have some education. Some.
Yeah.
So why is that? Why is it that they need you there doing that?
Sure. Yeah, no, it's a really good question. The biggest thing is certainly the innovation that comes with it. And, especially for a company that I work for, Arthrex, we're a private company. And so we are constantly pushing innovation. The president of our company just reinvests money that we have right back into new technologies. So part of it is, it's not just a money thing. Hey, doc, try this or try that. You're really helping them treat their patients better, which is, very important, but also ways that we can be efficient with their time, from anything to the size of the incision, to the approach to get down to wherever it is. Say it's a bone in the foot. There's different techniques that we have to get down there, say, versus another approach where they have a huge scar on the top of their foot. Like, that's very important.
So based off of like the prosthetics that you sell, there's basically a different way of going about installing these into people that the doctors would normally go about with maybe other prosthetics or things. So you need to be there to say, okay, with this specific thing, this is how you need to go about it, essentially.
Right. And I guess technically the definition of prosthetic is slightly different than, what we have and what's around us now. These are considered implants because we're implanting them into the body. But with that, there's also even instruments to help get to those points. So if we got into like real specifics, one of the, and I'm not trying to just have a pitch on our company, but
I'm sold.
But one of them is, we do something for a bunion, right, in someone's foot, and they have the bone, their tarsals kind of in varus, the other one's in valgus.
Right.
Doesn't matter. But we have a plate.
Who gives a shit?
But generally that way that was done was a dorsal plate. So a plate would be on top of the metatarsal, and it would help lock that joint in place. We've come up with an approach that comes plantar. So it's actually considered plantar medial. So it's like on the side of the foot, and the plate actually rest on the side and plantarly on the bottom of it. So whatever, it's not dorsal, it's plantar, but that means the incision's different, and it's a really strong construct. So, that's one example of, say something like in the foot, but when we get into some of the real rotator cuffs, the ACLs, like some of the big ones, we have some really cool innovative stuff of not just the devices, but like I said, the instrumentation to properly and effectively get what the doctor wants to get done.
Okay.
And then one of the points that you kind of brought up before earlier too is, like kind of the question was like, why are we in the room, right? I mean, sure, we make the sale, the doctor does it. Well, what happens if something goes wrong? Which I've been in before. A screw breaks. Not our screws, of course, but
Screw that.
Yeah, exactly. But like a screw breaks, or I've seen it before where a doctor put in a staple and it was the wrong size, and he turns around and he goes, "How do I take this out?" And you're like, "Yeah, there's a way."
Well,
there's a staple remover.
He knows how to do the surgery, but more about the thing that he's doing with the surgery almost, right?
100%.
So it's almost like you two are kind of teaming up, like the doctor who's like, hands-on, I'm doing the surgery, and you're kind of the guiding hand, like, move your hand here, do this, do that.
Yeah, I mean, like, honestly, yes. There's a point where they're going for the drill, and it's like, hey, doc, just drop your arm a little bit instead of having that pitch. But I think one of the words that you just used was team, and that's certainly, I had a doctor tell me this actually when I was doing personal trainer previously, who was a doctor. He was a vascular surgeon, and he was saying that you're starting to see the medical field switch from where it used to be like, the captain of the ship, right? The doctor was the guy who, would do everything. And you're starting to see that switch partially for insurance purposes, like their liability goes down, but secondly, to have an environment where people can share ideas and help, remedy a situation. So as much as, I and my coworkers were part of that, I have tons of respect, obviously, for the doctors, for all the circulating nurses, for the scrub techs who are the ones, doctors like Scalpel, and like they're the ones, they know a lot. Everyone in there knows a lot. But then the residents, the medical residents are great. They're the ones who probably really help myself refine what I know, because they like asking the questions. Doctor has tons of stuff going on. And these, men and women that I've worked with, the residents, they're still learning all of this. And so you have dialogue with them. PAs are in there as well.
Yeah,
so
who do a shit ton.
They do. And so it's really cool just being part of the team. And like I said earlier, trying to help out. But then the big part is that consulting. God forbid something goes wrong. All right, it's cool. We're gonna figure this out together. But then also trying, X instead of Y. And with that, yeah, sure. Again, there's like a sales aspect of it. But it's really, like I said before, trying to provide the best for the patient, and help the doctor out and try to reduce OR time and all that stuff. So it's very exciting. There's a lot of work that goes into it, but I'm fortunate to be here.
Yeah. You can tell you're jacked up about it. Like,
That's
even
the
we were
coffee,
talking
man.
off
That's
Third one of the day.
40th cup for the day.
4 and it's 2:00.
So go into like your educational background a little bit. Not even just educational, but like what were you doing before this? You know, like what were you doing before this? What was your educational background? Talk about kind of what led you to this point.
Yeah, sure. So, I guess we'll kind of start with, grew up around this area. Knew Nick from when we were, elementary school? Yeah.
Like 9.
Yeah,
You were the new kid in 4th grade with like a super tight sweatpants. And I was like,
I knew this was going to come up.
saved it just for today.
All these years.
With a football in your hand. We're like, cool football, man.
30 yards. Right no, I've always been into sports. Been fortunate for that. Pretty athletic family of, no one like played in college or anything like that. But, my dad can throw a football and shoot a basketball and hit a golf ball and like all those little things. So it's always been part of my growing up. High school, that's when I really got into lifting weights. Partially I think it was just being like a young teenager, and it's pretty cool. You kind of care about like the aesthetic and how you look. But there's no doubt Arnold was a big motivator for myself.
I've heard of
inspiration. Yeah, I mean the two things, all jokes aside, were pumping iron. And the Arnold Encyclopedia of Bodybuilding, which I think you broke that book, actually.
I did. I stole yours, or you gave it to me, and then I fucked it up somehow.
Yeah, exactly.
The pages stuck together. We don't know why.
I did notice that, actually.
What the hell is page 40 to 55?
Exactly. But, that got me really into exercise, and I knew it was something that, I was pretty passionate about, and I just like the way my body felt. And I was also really into lacrosse and football at the time, so there was no doubt there was the performance aspect of it. And then I was applying for colleges, and was looking at, I was looking at like certain schools, maybe get into finance and all that, and I was like, this is just not for me. Like I know what I like, and so Springfield College is where I ended up going to school and played lacrosse there. But I also they had a really good applied exercise science program, and so got into that, and then ended up morphing into, and I'm sure we'll get into some details with it, but then ended up going back there for grad school. Right out of grad school, got into cardiac rehab, which I was doing. Didn't love it. I loved the population and the people that really wanted help, but it was just like a little slow. I didn't like the whole protocol of just like, it was pretty much the same linear progression for everyone. And
so what, as far as what, for like the rehab process?
Yeah, right.
So going to cardiac rehab a lot, like the name comes out there a lot. It seems to be like a popular route for like exercise science majors. And things like, so what is cardiac? What is that?
Yeah, right. No, definitely good question. Cardiac rehab is, I've always explained it as it's working as a physical therapist for people with cardiovascular conditions. And so I don't want it to sound like at all that I have a physical therapy degree or certification. Not the case at all. It's generally exercise physiologists that do that. But a lot of the patients that we work with were people that were post-MI, post-stroke, post-heart attack, that have conditions, stents put in, this and that. I worked with one guy with a heart transplant, which is amazing. This guy is 2 weeks out.
That's crazy.
2 weeks out, and it's so vital for them. They used to treat patients with cardiovascular disease with bed rest, and they found it was killing them. And yeah, seriously. And so they found out now some people, 4 days after heart attacks, they encourage exercise. So we were working with people
Makes
in that.
sense, though.
It does. When you look at some of the, basic physiological principles, it absolutely makes sense.
It doesn't seem to make sense to, hey, let's try to get your heart working again. So lay down and don't do anything for a week. It doesn't make sense.
You know what? And to their credit, and just the way things progress, I think especially when it comes to the heart, it's supply and demand.
Yeah.
And that's essentially what a heart attack is when our demand is too high for the supply. So I think maybe they were focusing more on the demand aspect of it, where I think anatomy and physiology kind of principles, professionals are focusing a little bit more on the supply. How do we things from vasodilation to
which is what
veins widening, getting bigger. It's a muscle pump. It's
Okay.
like what we see, but that's huge. We have the opposite of vasoconstriction. That means more work for the heart to have to do. So,
which is more common?
Definitely vasoconstriction because, we certainly how high cardiovascular rates are. But now, that gets tied into hypertension, right? And so say, I always like using the example for hypertension is imagine you have a hose and you increase the amount of volume in that hose.
Meaning like water traveling through the hose.
Exactly. You're going to have more volume and you're going to have a higher pressure. So that means when the heart has to eject blood from the left ventricle, it's going against a much greater force, which means it has to work harder. So that's why as you hear of left ventricular hypertrophy. So the heart, increases muscle size, which sounds good, but then in that ties back into now the demand of what the heart needs is higher. So that means we only have about 5 liters of blood in our body. So we're not going to make more blood. It's not going to work. We're going to have to become more efficient. Yeah. So the vasodilation is a huge part of it. And when we get into some of the other stuff about the low carb, it's really fascinating about that excess volume of blood.
Yeah.
It's actually pretty cool. But yeah, that was my stint with cardiac rehab.
And so and being a low carb guy, I'm interested, like, what role, if at all, did the nutritional process play in cardiac rehab, if any at all? Did you use any of that or no?
I think it should be everything.
But it probably wasn't implemented the way
wasn't
you
at
liked.
all. Yeah. And I was working with some doctors who, this is their profession. And I'm some dude like right out of college, 23, 24 years old. And it wasn't something that, I kind of knew my role, and I definitely choose who I pick this battle with, because I've done it a lot, and truthfully, it's exhausting. And so I'm not just trying to be, like two rams bumping their heads together back and forth. It's now my approach is a little bit more educational. But to answer your question, there wasn't much, and it was baffling to me. And actually, let me back up slightly. So before I was doing cardiac rehab, we had to do internships for my grad program back at Springfield, which was I have a master's in clinical exercise physiology, and I was really into metabolic rehab. So that is things related to metabolism. And so I had an internship at Joslin Diabetes Center in Boston, biggest diabetes center in the world. Awesome. Great place. They did a great job of educating patients on how to manage both their type 1 and type 2 diabetes, which I find fascinating. But I would have very, very good educational conversations with some of the endocrinologists, some of the registered dietitians, some of the RCEPs, registered clinical exercise physiologists, about why are we prescribing whole wheat bread instead of white bread? Like, really? Like, that's the best that we can do?
That's what's killing them, dude.
And when we have a condition, like, we talked a little bit before of, diabetes essentially being glucose intolerance. Like, their body is not able to tolerate glucose. Our best solution is just to have a carbohydrate source that's a better glycemic index. Like, not good enough for me. Not good enough for me. And so that's where I was able to, and it was actually kind of fascinating, to be honest, without using any specific names of, professionals that came to me. They're like, Cory, I hear you. I swear, I hear you, but we're limited to that. When you have certain, when you're associated with, say, the American Diabetes Association, American Heart Association, you have to abide. Yeah. And it's
like, this is the food pyramid that the government gave you. This is what grains and bread are the most important, biggest at the bottom, and boom, I see your head.
It's just, you
having a panic attack? You all right?
Talk about, blood pressure. I mean, it's just, and I was taking that fight on definitely personally. Because you feel bad for these patients, like, what do they do? And then when you get into, especially when you get into diabetes, I mean, you're talking, increased chance of overall death, like, no question. But amputation, number one cause of non-traumatic amputation, number one cause of blindness. Neuropathy, people losing feeling throughout their body. Like I said, the amputation stuff, kidney failure, hypertension, 4 times increased risk of stroke. These people, and they are like our family members. They are people that are loving people, and you really feel for them when they, they've had poor advice, in my opinion. So that's how the metabolism kind of bled into the cardiovascular work. And then after I did cardiac rehab, there was a personal training studio that in Westchester, in Mamaroneck, New York, that I ended up working at. And, listen, there was like a master's degree, yada, 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 maybe a little bit like overqualified for that. And I use that, with quotes. It was an excellent opportunity for me because it was a small facility where I had the ability to do what I wanted, finally. And I ended up starting a diabetes program there. So I got to work with patients directly. Listen, I'm not a registered dietitian. I'm not a registered nutritionist. So, sure. You have to be careful with that. But certainly just having patients educate themselves. And the most important thing, I think any of us that are, care about science or, other aspects of that is why, asking that question, why? And that's what I wanted, not so much me asking these patients because they don't know, but I want them to ask their doctors, why? Why should I do this? Why? And it's a fair friggin' question.
Yeah, absolutely.
It's a fair question.
Well, and so transitioning from the diabetes program you were in before to now, all right, I'm a trainer, I have my own diabetes program. What did you take from that? What did you do differently?
Yeah, right. In terms of, so technically when I was at Joslin, I was there as an exercise physiologist intern, not a nutrition intern. So what I learned from there was, certainly just the basic, mechanisms of glucose uptake with exercise.
Okay.
It's pretty much a miracle. And
meaning like how your body uses it?
Exactly.
Okay.
So you can have, patients that, diabetics that have excess glucose in their blood because they're resistant to insulin and now they can't get that out of there. And that's what's going to cause the blindness, the increase in stroke, glycolytic end products. I heard someone make the example. It's like, pouring molasses on like a keyboard. Like that's what happens when we have all this excess glucose in the blood. It just becomes the efficiency is very poor.
And glucose, so we're on the same page. Quick snapshot of glucose and how that relates to carbs.
Yeah, sure. They're the same. It sounds, I'm not trying to sound like a jerk, but all types of carbohydrates break down to glucose. I don't care if it is the most, the lowest glycemic index carbohydrate there is, which I actually don't even know what that is. But let's say we're talking about like a quinoa which actually I don't even think that's low in the glycemic index, but, a whole wheat bread or something like that. It's all going to break down to glucose. The question is, and what the glycemic index is how quickly does that happen?
So for someone who's like, dude, I have diabetes. Like, I need to worry about my blood sugar. Like, why do I care about my carb intake?
Yeah, to me, it's like it's like saying, I need oxygen. Am I going to breathe air from outside? It's like they just so go together that you can't even differentiate the two. And I agree with that individual that. They do need to focus on their blood glucose. But, diabetics aren't there with low blood sugar. And I say that cautiously because there is a condition called hypoglycemia where, they have low glucose in their body. But that's the body being, the hormones being so out of whack. And one of the big ones being insulin is that they go from very high hyperglycemia to very low hypoglycemia. They don't have that balance of where guys like us are, healthy individuals with normal function in pancreas and normal sensitivity to hormones have. So, it was brutal, right? Because now they are worried about having high excess glucose. But when you have hypoglycemia, it is bad. They did one study at Johns Hopkins University where they compared hypoglycemic drivers and drunk drivers in simulated driving. And the hypoglycemic drivers did worse. They did worse than drunk drivers. If you have anyone who's a diabetic that you've talked to that has experienced hypoglycemia, which is generally, carbohydrate or blood glucose below 70 grams per deciliter.
So guys, this is low.
Low, right.
Okay.
It's bad. Like they fear it. You are confused. I've heard stories of, one guy, when I was at Joslin, we lived out in Washington State and had a bout of hypoglycemia during a snowstorm. And I don't know if he ran out of medication or what it was, but he ended up taking all of his clothes off and just walking in the middle of the snowstorm down the highway. And a cop found him and was like, "What are you doing?" And he was just like so confused. So the point is, they have to really
I got no glucose.
Do you have a donut on you?
You hear stories about diabetics on and I hate to use I don't want to identify anyone by their condition. So individuals with diabetes, not being able to go on airplanes because they might have this like the fruity smell on their breath from that's actually gonna mean someone has high glucose. The point is with diabetes, and what makes it very interesting is that there's these ebbs and flows, and that's all gonna stem from really insulin resistance, which I'm sure we'll get into. But that's where it went into, again, me kind of taking that fight head on, and really feeling for these patients and being like, it's so confusing, and you've been getting shit advice, in my opinion, and trying to help them with that. So to me, the metabolism was everything, and that all kind of started with my work at Springfield, and I was able to extrapolate into real life stuff.
So how fast can someone go from hyperglycemic to hypoglycemic? Say you work with a client that has that issue, or someone that has that issue, like you're saying, they have bouts of really high blood sugar and then they just drop. Like, how quickly can that happen, and how do you have to monitor their exercise? Yeah,
it's it's a little bit of a loaded question because you can start with, okay, is it type 1 or type 2, right? So type 1, 10% of the diabetic population, their body doesn't produce insulin. That's considered child onset. Generally, type 1 diabetics have it early in life. It's an autoimmune disease where the beta cells or the pancreas are attacked by its own body until they don't produce it. The fortunate thing about that is that we can bypass that by just taking insulin, right? That's where you see type 1s.
Yeah, okay.
They have the patch, or they just take it themselves.
And so that's literally from your pancreas just being like, nah, yo.
Yep.
Ain't no insulin here.
Yep, pretty much.
Okay.
It just doesn't secrete it. And for whatever reason, we don't know exactly why, but again, that's 10% of the diabetic population.
And that's what I want to get. So type 1, only 10%. So 90% is type 2.
Yep.
And type 2 is, for the most part, curable or just controllable by diet or what?
Yeah. Good question. I've heard people say, yeah, it is curable. Yeah, it's not. So type 2, the hallmark in that is insulin resistance. So insulin, just for people to know, we digest a carbohydrate meal. We break it down into glucose, right? That's the final stage of it. Mm-hmm. We now have to get that glucose into our cells. Insulin is the hormone that when we notice that glucose is in the bloodstream, we release from the pancreas. Insulin takes the glucose, brings it to the cells, and the cells take it in for energy. The problem with that is that, and we'll learn, especially with hormones, is that we become resistant to hormones when we have them in overexposure. When there's too much of it, we become resistant. So now, let's say you have a normal meal of whatever it is. Someone has, let's say, 50 grams of carbohydrate at a meal. Mm-hmm. They might use X amount of insulin, whatever that number is, to get that 50 grams out of the bloodstream and into the tissue to work. Well, if they have that over a lifetime, and they're becoming resistant to insulin, well, now they need X plus 5 insulin, to get that same amount of glucose into the cells. So that's a vicious cycle where the body's going, all right, I have to keep dumping insulin out. And the body's going, all right, you keep doing that. I'm not really noticing it. And so then at the latter stages of type 2 diabetes is when their pancreas goes, okay, I'm done. I'm not producing anymore. So now you have someone who's insulin resistant, okay, and they have to take insulin as well. It's just like, it's crazy. They have to account for their liver, and so it's very crazy. So for your question before of, what that shift, it depends on those two. But say the point I brought up earlier about exercise and why exercise really is a miracle. I think of all the conditions, certainly cardiovascular disease, but diabetes, it's fascinating what we can see with people helping. But there's a miracle that occurs where, we don't have to get into all the details, but inside the cell, right? So glucose is in the bloodstream, insulin's there. Inside the cell, there's this thing called the GLUT4 transporter. And so that comes to the wall, and the insulin has delivered glucose. It grabs the glucose and it brings it into cell to be utilized for energy. With exercise, we actually get that response of that GLUT4 transporter moving to the wall of the cell without insulin being present. So you might even have patients, I've seen it numerous times, where patients will come in, you want like a normal glucose level to be somewhere, like for us, it's probably somewhere in like the 90s, maybe around 100. The criteria for diabetic or someone to have diabetes is 126 on 2 separate occasions, fasting blood glucose. So they're fasted, their blood glucose is the 126. And so you have people that, might have glucose in the 150s. And all of a sudden they exercise and their blood glucose afterwards 90. And they're like, what? I didn't take any more insulin. But it's a little bit of a crazy, situation because say, excuse me,
Coffee
they do.
burp.
My eggs and bacon. But say they, with lost my train of thought. But say they're taking insulin as well, right? So now they have to balance between insulin bringing that glucose level down and exercise. So that's where someone might all of a sudden get into hypoglycemia because maybe they don't understand their sensitivity to insulin. They take it and they exercise. Now they're down at like 70, 65, and they feel horrible. And so then they become, afraid of that as well. So it's this weird, like, kind of balance that has to exist that they have to deal with every time. And on top of that, my last point with that is that that's what we see with aerobic exercise is blood glucose going down. It's pretty consistent, but it definitely varies on the individual. But resistance exercise, sometimes acutely, blood glucose goes up. And the body's like, what? And the person's feeling frustrated. Well, it's a little bit of, a false sense of something bad happening because, yes, their body has actually secreted more glucose from the liver because, exercise is essentially, if we think of like our evolutionary kind of backbone, is a sense of stress, right? We might be running from prey or might be chasing down food.
Yeah.
So the body is going to reduce some glucose, or it's going to secrete some glucose. And again, normal people that have normal function in pancreases, we're going to secrete a little bit and we're going to be good. These guys might dump them out. So now all of a sudden their blood glucose is up. However, their sensitivity to insulin within the next 48 hours is improved. So they might not see the acute effect. They might go, wow, I started exercising, I was at 130. I did resistance training, I'm at 150. Oh, this exercise stuff is stupid. But it's like, all right, yes, but your sensitivity
But that's
to
just
insulin,
your body doing its
evolution
natural
purpose.
work. Yeah.
Exactly.
So then you're more able, when you say insulin sensitive, for people out there that don't know, you're more able to absorb the glucose into the muscle cells after 48 hours after working out?
Yeah, I would say the amount of insulin that you need to absorb the glucose is reduced. And if we learn and we get into, which I'm sure we will, about insulin's role in the body, we'll see why having less insulin levels is vital to health, longevity, well-being, and it's pretty well documented. It's very well documented.
Word.
But that's definitely a big part of it. So I'm just fortunate with the kind of exercise science background that I was able to do work with pulmonary. I was able to do work with metabolism. Able to do work with cardiovascular because it's really fascinating stuff. And it's a cheap medicine. Yeah, it really is. As cliche as it sounds, you have a lot of power that you can help these people, empower themselves to treat their conditions. So it's a pretty fascinating stuff.
Dope.
Yeah.
All right. Well, we're going to take a quick break. Then when we come back, we'll talk a little more about specifically low carb diets, why people should be doing that, why people shouldn't be doing that, whatever, all that.
Awesome.
So take a quick break and we'll be back in a few minutes.
More coffee.
For you. No.
Want more of the Strength Students podcast? Go check us out on Instagram, Facebook, and Twitter. Also, make sure you leave us a 5-star review on iTunes and on Stitcher. Stitcher, I just met her.